you who are working in St. John's, you may have met me or you may be aware of me. I work in the Department of Immunology and Rheumatology. I have done my fellowship in rheumatology from CMC Vellore, where I was working for quite some time. So, shall we go ahead with the presentation? So, I
Please.
have a lot of medical practice requires an art rather than a science behind it, and this concept is most relevant for the practice and use of steroid. That is why I have put this particular image. And as we go through the presentation, we will know how much of uh, prescribing steroid is art and how much is science. So let us go ahead. So there is no better time to discuss steroid than now, because the steroid is the most effective drug which has been found to manage a COVID pandemic, and this is the only drug which has been found to have some mortality benefit in the management of moderate to severe COVID. So there is no better time to know about this particular drug than now. And this will be the outline of my talk. I will be talking briefly about the various glucocorticoid molecules and their biologic equivalence, which is very important for our clinical day-to-day practice. I will also be briefly discussing about the mechanism of action, in particular the genomic and non-genomic pathways and the various doses at which each of these will come into play. There is just a slide on neurologic indication. My basic idea is not to discuss these indications, and the rationale of the various dosing, the timing at which it is given, and the use of low dose steroid, and the how and why these pulse steroids are found to be useful. All those things I will be discussing. I think this dosing and rationale of use is the most important part of my presentation. I'll be briefly discussing about pregnancy and some special situations like vaccination during high and moderate to low dose steroid. I will discuss in a little bit of a detail about the side effect profile and the monitoring which is required in those who are on low dose steroid, as well as immediate complications associated with high dose steroid. I'll also be projecting one or two slides about how to assess HPA axis suppression and its management. The other important thing which I would like to discuss is changing paradigms in the glucocorticoid use. I am not going to discuss the guidelines or recommendations for use in neurological disease. I have just projected one slide about it. But my main intention is how, especially in our practice, the dosing of steroid and the tapering schedule of steroid is finding its place in recommendations, and how it is changing over time. As compared to what was our initial practice, of late the practice is shifting towards shortest possible time of high dose steroid, and the tapering protocols I will be discussing slightly. So going to my next slide. These are the three eminent gentlemen who received Nobel Prize in for medicine, physiology or medicine in 1950 for their discoveries related to hormones of adrenal cortex and their structure and biologic effects. So we know we are using this molecule for around 70 years now, and still it remains, a lot of it remains more of a empirical or practice oriented usage rather than good uh, uh, like evidence based backup for how and why we use steroid. So briefly, this is about the pharmacology of steroid. I would like to just highlight that this is the basic steroid molecule, which is endogenous, and it is derived from cholesterol. So if you can see, all these synthetic steroids are maintaining this basic backbone, the molecular structure, and only few of these side chains are differing, which will determine their pharmacokinetics. So hence it is, the mechanism of action is more likely to mimic whatever is happening, whatever is the mechanism of action of this endogenously derived steroid. Therefore, these suprapharmacological doses which we use is likely to produce side effect which resembles Cushing syndrome rather than some entirely new kind of a side effect. The other thing is the absorption of these steroids, oral steroids, is quite excellent, and it is reaching the tissue of interest in quite a good concentration. So bioavailability of any of these steroids is quite good. The this other part of this diagram, they are actually showing these two enzymes, this 11 beta hydroxy uh, dehydrogenase 1 and 2. These are the two isoforms. This isoform is present in tissues where mineralocorticoid effects are most important, like in, for example, in the kidney. This isoform is present in those steroid responsive tissues. So there is some issue with the sir. Hello. The slides are not visible to me, sir.
Have you clicked anything? Any other? I will share again once.
Yeah, yes.
You can take control again and move forward.
Yes. So we were discussing about this slide. So that the beauty of this enzyme is it is present wherever the mineralocorticoid effect is most relevant. Therefore, like most of these synthetic steroids are having very little mineralocorticoid effect because of the modifications which are done. So the most mineralocorticoid effect is there in hydrocortisone and the least is there in dexamethasone and betamethasone. So the other important thing is this particular enzyme is also expressed in placental tissue. That is why the steroid which we give during pregnancy, mostly the prednisolone and all, is unable to cross the placenta because it is inactivated. This is also an important concept behind steroid type of steroid usage and dosing, etc. in pregnancy. So this last part of this figure, I have just projected the glucocorticoid receptor. So there are two isoforms of glucocorticoid receptor, glucocorticoid alpha and beta. The main efficacy of glucocorticoid is by alpha, and this dimerization of this glucocorticoid receptor alpha is involved in transactivation and transcription. But most of the transactivation, that is activation of these glucocorticoid response elements, these are the genetic elements which are responsive to glucocorticoid induced activation or repression. So these transactivation, that is activation of some of these genes, is mostly by this dimerization. But if you see trans repression, most of our immunomodulatory effects are by trans repression, that is inhibition of some of these GREs. That requires just a single enzyme. The dimerization is not really required. I have just projected these other isoforms because of another important concept called as glucocorticoid resistance to glucocorticoid, which we do come across in around one, like according to literature, 1/3, but we do come across a certain number of patients in our practice as well. So one of the mechanism is by this GR beta isoform in combining with GR alpha and hence preventing this its effect on the glucocorticoid response element. That is why I have projected this image. So let us go to the next slide. So I am not going into the details of what effect it has on individual cells. Our main interest is its immunomodulatory effect. It suffices to tell that it has a very broad spectrum anti-inflammatory agent. Unlike a lot of other immunomodulators in use, like we have more focused molecules like rituximab and TNF, which are targeting a single cytokine or a group of cytokines like JAK-inhibs. Glucocorticoids are likely to have a very broad spectrum anti-inflammatory effect. Hence, it is going to affect a diverse cell types like innate adaptive immune system. It is going to affect lot of pathways which are involved in immune system. Therefore, it is likely to predisposed to infection at a higher rate than some focused molecules like rituximab. This is what I wanted to convey by this slide. And the other important thing is the targets of glucocorticoid is likely to differ between different disease contexts as well as different disease phases also. So at different phases of disease like rheumatoid arthritis or lupus, the response to steroid is likely to differ. So this is the main mechanism of action. This is at the doses which we give, the chronic oral load moderate to high dose steroid works by genomic pathway. So at doses like about like 20 mg, 30 mg, up to 1 mg per kg. This is the main mechanism of action. So glucocorticoid receptors they easily pass the cell membrane. Their main effect is in the nucleus. So after binding to the glucocorticoid receptor in the cytoplasm, some of these associated proteins like HSP are released. They have additional non-genomic effects on these cells. This glucocorticoid receptor goes into after binding to its receptor, the glucocorticoid goes and attaches to some elements called as glucocorticoid response elements, and it causes inhibition or activation of certain genes. So as I have previously mentioned, the main effect is inhibition of pro-inflammatory molecules, mainly NF kappa B, AP1, etc. So this is the main mechanism of action, and it happens to be by transrepression. So some of the immunomodulatory effects are also by transactivation, but that forms like minority, like less than 10 to 20% of its immunomodulatory effects are due to transactivation. Most of it is by transrepression. So I will also be discussing about non-genomic effects of glucocorticoid in a subsequent slide. It suffices to say that there are various ways by which this non-genomic effects comes into picture. It happens at high dose, that is pulsing. The basic concept behind pulsing is for this non-genomic effects to come. I'll be discussing about it in the subsequent slide. So these are the common clinical uses of systemic steroid. I'm pretty sure that it is not a complete list. So from varied specialties continue to use steroid, and in allergy, dermatology, endocrinology, gastroenterology, neurology, hematology, rheumatology, ophthalmology for various indications. So coming to neurological indications, main neurological indications are CIDP and its variants, inflammatory myopathies, giant cell arteritis, acute relapse of multiple sclerosis, TB meningitis, and in some cases of pyogenic meningitis, tumor edema, CNS vasculitis, etc. So some of these are jointly managed by both rheumatology and immunology, and I'm quite familiar with these. So let us go to some of the pre-existing conditions which we need to assess before steroid initiation. One of the most important considerations before steroid initiation is the age of the patient. The elderly patients are more likely to be predisposed to the complications associated with long-term steroids, like infection and uh, osteoporosis. That is one of the important consideration which is not the part of the list. Presence of infection. So unless patient has tubercular meningitis, the steroids are not prescribed in the presence of active infection, and it is likely to the patient is likely to develop frank sepsis and mortality associated with it if we are giving high dose steroid during active infection. So this is the most important thing which we need to, according to me, this is the only absolute contraindication to start high dose steroid. All others are relatively, we need to keep it in mind if the patient has uncontrolled diabetes, poorly controlled hypertension, heart failure and peripheral edema, because steroid is associated with fluid retention. So this may get worsened if there is pre-existing glaucoma, peptic ulcer disease, already they have low bone density or previous osteoporotic fracture. These are all considerations to modify steroid or consider alternate agent if any patient requires steroid initiation. So coming to the most important aspect, dosing and guideline, as I have previously mentioned, it is still remaining an art than science. So I will be going through what are the commonly practiced things about dosing. A lot of my knowledge about this dosing comes from this article published in 2002 in ARD. There are very few guidelines and studies which support the dosing choices and tapering protocols which are in practice. And one important mantra which we have to use is use of the lowest dose of glucocorticoid for the shortest period of time needed to achieve treatment goals. This can be done by using initial pulsing if required, and then subsequently the long-term oral steroids can be started at a lower dose, and initiation of steroid sparing agent at onset of disease itself rather than waiting for the disease to relapse or after subsequently once we taper. These are the two practices which have been recommended. So this is the most important slide which I would like to discuss. So this particular figure is discussing at what dosages of steroid does each of these genomic and non-genomic effects come into action. So if you can see around doses of like 100 mg oral steroid or whatever IV steroid, these non-genomic effects starts to take comes into picture. And if you can see any dose which is more than 250, it is plateauing almost. So any dose of steroid which is more than or equal to 250, you will get your full non-genomic effect. If you come to genomic effect, around 30 mg of steroid, you see around 50% of our glucocorticoid receptors are saturated. But around like 30, more than 30 mg, anywhere between like 1 mg per kg. So you can see that all of our glucocorticoid receptors are saturated. So non-genomic effect starts at more than 100 and maximum effect is achieved by 250 mg pulse steroid therapy. So these are the definitions which are in practice. So we refer to low dose steroid when it is less than 7.5 milligram of prednisolone or equivalent dose. Medium dose is 7.5 to 30. Any dose which is more than 30 mg is considered as high dose, and very high dose we refer to more than 100. Any dose which is more than 250 mg of prednisolone equivalent is considered as pulse steroid therapy. So we need to remember that depending on the severity of the condition, we can use the pulsing anywhere between 250 to 1000 mg. And I will be coming to the like number of days and all in the subsequent slide. This last figure is also an important thing about the relative potencies of individual glucocorticoids. So as you may already be well aware of, this is prednisolone. So dexamethasone and betamethasone are at least 5 times more potent than prednisolone in with respect to both genomic and non-genomic effect. Another important thing which I would like to project is this non-genomic effect, that is this pulsing effect, that is little bit more in methylprednisolone, hence our rationale of using methylprednisolone for pulsing rather than other steroid. So if you can see that as compared to prednisolone, methylprednisolone has more of these non-genomic effects at equivalent doses. So this is a diagram which is depicting what are the mechanisms behind these non-genomic effects. Why are we pulsing at all? So if you since we know the physiology of this gene transcription, etc. So if we are expecting the glucocorticoid receptor to have some effect on the genes, the transcription level, it is going to take days, if not weeks. So the effect is likely to start in say 1 week or 10 days or like at least 3-4 days. So since when there is an organ threatening manifestation, when there is some neuropathy which is progressing, or when there is a vision which is involved and we think that we can save the vision by pulsing, this non-genomic effect comes into play. They work at this membrane level. So one thing is they saturate this glucocorticoid receptor and they are modulating the kinases which are associated with the glucocorticoid receptor here. This is the MAP kinase. So they are modulating the kinases. So they are going to inhibit these kinases. The other thing which they do is they sequester. So they sequester calcium and sodium. They have some interaction with the membrane and the cycling is involved. The other thing is this: once this glucocorticoid binds to glucocorticoid receptor, some of these chaperone proteins come out and they also have some non-genomic effects. And these are further detailed here. So it is going to compete with this phosphoinositol 3 kinase. This is a membrane, around the membrane this effect happens, and it is going to prevent this downstream AKT signaling, and it modulates kinases, and it involves this chaperone protein which have some non-genomic effects. So these are the effects which we are looking for when we are pulsing, and it starts within hours, like few hours of us giving glucocorticoid, some 3 to 4 hours at least. So this is the concept behind pulsing. So the other thing which I would like to discuss is dosing of methylprednisolone pulsing. As I have previously discussed in the previous diagram, the effect may start at as low dose as 100 mg, and maybe the optimal effect will start at 250 mg itself. So the practice of this 1 gram methylprednisolone for 5 days is going to increase the cumulative dose of steroid, which will have long-term effects on bone. And the risk of infection is also likely to be higher, especially in diseases like lupus, where when there is active disease, they are also predisposed to have sepsis. So this particular study, which was published in Lupus 2002, I found it interesting. Although it is a small study, it has compared 26 patients of lupus versus 29 patients of lupus who have received low dose versus high dose pulsing. They have defined low dose as 1 to 1.5 gram and high dose as 3 to 5 gram. And they have found that both the short term and long term outcome is no different between this low dose and high dose pulse steroid which is used. And the other thing which like you can see here, this is a, I think, short term outcome and this is long term outcome. The SLEDAI has responded similarly in those who have been used a low dose pulse versus those who have used high dose pulse. All these indications have been for organ threatening major organ manifestations. The uh, and what they also found was the incidence of serious infection is very less. See here, the p-value is 0.04. If you can see, the low dose people have developed 9 episodes of serious infection and high dose people have developed 20 episodes of serious. Of course, this situation is a very peculiar one. As I have told, lupus per se is predisposed to sepsis during active phase. Now let us come to some pharmacokinetic things, modes of administration. So once daily dosing is preferred due to increased risk of adrenal suppression and systemic side effects with divided dosing. As you are well aware of, the cortisol, the endogenous cortisol secretion is maximum during early morning hours, and we would like to match it by giving our morning doses. And if we give it in the evening or if the patient inadvertently takes, that is likely to suppress this endogenous cortisol secretion in the body and likely to cause more HPA axis suppression. So as I have previously mentioned, the oral bioavailability of most of these drugs is very good. Severe hypertension and bradycardia is associated with pulse therapy. I have myself come across with high dose DEXA and high dose methylprednisolone. Bradycardia, I have come across with many of these patients. It usually settles if you switch over to little lower doses of steroid. So if the patient already has hypertension which is uncontrolled or some other rhythm disturbances, it requires monitoring during pulse therapy. And alternate day dosing. There have been older literature where they have used twice the usual daily dose on alternate days, and they have proposed that it is likely to be less, it likely to have less effect on HPA axis, and I think it is considered an unsuccessful form of therapy, and there is no evidence to say that it has less HPA axis suppression. In rheumatology especially, we use a lot of depot preparation for control of some acute articular flare, etc. And it works quite well, and its effect lasts up to 20 days. So we use this approach to not give oral steroid. We tend to avoid giving oral steroid, and we just use this depot preparation. Hello? Yeah. Yeah, it's still moving. Yes. So I'm not discussing the topical and inhalational routes because this audience, I don't think it is really indicated. So this is the equivalent doses of various steroid. I have previously shown the equivalent dosing of these steroids. So if you take 5 mg of prednisolone, it is equivalent to 0.75 mg of dexamethasone. This is most useful during acute situation. At least in rheumatology, we are having this habit of giving dexamethasone injection during the initial admission, acute situations when the patient is admitted. So if a patient is 60 kg and you would like to give 60 mg of prednisolone, it is equivalent to 9 mg of dexamethasone. So this table is a very useful table when we would like to convert the prednisolone to dexamethasone and vice versa. The other thing is hydrocortisone. If you see, 5 mg of prednisolone is equivalent to 20 mg of hydrocortisone. So if your patient is on, say, 10 mg of prednisolone and he has come with some sepsis or something and you would like to change over to hydrocortisone, you have to convert likewise 4 times. So that is around 40 mg or maybe some 25 mg 8th hourly will suffice as a stress dose. The other thing is this relative anti-inflammatory effects I have already told. You can see that dexamethasone is around 4 divided around 10 times more potent than prednisolone. The other thing is the duration of action. So dexamethasone has a longer duration and hydrocortisone has a shorter duration. Of these steroids, the least potent steroid is hydrocortisone, and that is why we are using it in situations where we are not sure about the underlying sepsis. And the mineralocorticoid effect is highest with hydrocortisone and least with dexamethasone, in that order. Coming to pulse, uh, the other ways in which this pulsing is used. So this pulse dexamethasone has been used in immune cytopenias quite successfully, and it is part of their guidelines now. So they are using pulse dexamethasone 40 mg OD for 4 days whenever there is like ITP, acute ITP, flare of ITP, when the counts are less than whatever 20-30,000 or less than 10,000, and they have a good response, and it has probably has equivalent response to pulse methylprednisolone, and it is also successfully able to reduce the dosage of steroid to which the patient is exposed. The other thing I would like to, this is our observation among rheumatology practitioners, this monthly pulse methylprednisolone of 5 days, which is used for certain conditions like multiple sclerosis or even in myositis I have seen. It is around 5 gram of steroid, and if you calculate it, it is likely to be very high. The overall cumulative dose of steroid which the patient is likely to receive will be high and predispose the patient for things like infection and osteoporosis and AVN and all. And it may not translate into less HP axis suppression. Sir, I'm again not able to see the slides. Hello. Hello. Hello.
Yes, Dr. Ramya, we can see now.
Okay, sorry. Sorry for this inconvenience. Hello. Yeah, yes. Okay. So this is another thing, and the other thing which I found it interesting actually, the rationale of long-term low-dose prednisolone. This we use it actually. We use long-term low-dose prednisolone in both lupus and myositis, rheumatoid arthritis in some refractory patients. So if you see, the 2.5 milligram of prednisolone is going to be equivalent to 10 mg of endogenous glucocorticoid, that is hydrocortisone. And since if we add a patient on 2.5 mg of prednisolone every day, his availability of this endogenous glucocorticoid will double. So that is going to have some ameliorating immunomodulatory effect. So this is the rationale behind the success. So we tend to continue this steroid doses of around 5, less than 5 in patients for more than a year or 2 years if we think that stopping this is likely to result in failure. This particular situation we come across with hematological manifestations of lupus, even taking off 2.5 mg or 5 mg of prednisolone, like stopping it, will result in flare in many of our patients. So this is the rationale for it. So some of the pharmacokinetic alterations, there are a lot of ways in which the people would like to just keep the good effects, the immunomodulatory effect of steroid, and avoid the side effect profile of associated with steroid. So they have tried a lot of things. One is this timed release preparation. The drug is taken at night and the tablet releases prednisolone 4 hours after ingestion, so that it mimics this endogenous steroid pulse which happens, the circadian rhythm of endogenous steroid. This also has not come into practice, although there are 1 or 2 molecules which are there. We don't commonly use it, but it is a uh, important way in which we can reduce this HP axis separation. The another interesting molecule is this SEGRA, selective or dissociated glucocorticoid agonist. As I have previously mentioned in the mechanism of action, most of these immunomodulatory effects are associated with trans repression activity. So what they are proposing is, if SEGRAs can be developed and they have just the trans repression activity and they don't have trans activation potential, some of the effects like osteoporosis can be avoided. But it is a conceptually limited entity, and it has not come into like popular practice as of now, because some of the anti-inflammatory genes like these genes rely heavily on trans activation rather than trans repression. And it may not, and they have also found that these kind of molecules continue to have effect on the bone metabolism in the rat models in which they have tested. So just a slide on glucocorticoid resistance. From literature, what I found out is up to a third of lupus patients may have insufficient response to glucocorticoid. We also do come across, and we have a very difficult time managing such patients. And some of the mechanisms by which this may happen is increased expression of this GR beta isoform, to which I have referred to. So it is a transcriptional variant, and because of some genetic susceptibility, this variant may be expressed in higher percentages than usual, and this may affect glucocorticoid responsiveness. Some of post-translational modification of glucocorticoid receptor may make it less responsive to our exogenous steroid. And some of the target tissue, especially in patients who have not received adequate treatment and they are towards like different phase of a disease where they are less likely to be responsive to treatment at all, they may have reduced expression of glucocorticoid receptor. So if our target tissue is not responsive, it may be because the expression of receptor itself is modified. And there may be some disease-induced changes in the chromatin structure which may make it less responsive to steroid. So these glucocorticoid response elements, these GREs, may have some modification so that this glucocorticoid and GR alpha, this receptor complex, may not be able to access these GREs and hence may not have effect on the inflammatory pathway. So the other pharmacokinetic concepts which are of importance is certain drugs, most importantly phenytoin and rifampicin, which are in use still, like patient on ATT and he also requires simultaneously steroid for some other disease. The bioavailability of steroid is likely to reduce by at least 1/3. So we need to keep this in mind because of its interaction with these hepatic enzymes. And nephrotic syndrome with very low concentration of albumin and cortisol binding, these are the glucocorticoid binding molecules. They are likely to have the unbound concentration may differ, but the unbound concentration is likely to be similar. Bound concentration may reduce. So hence it is and the clearance also will be increased because of this whole thing. So the unbound drug will get cleared. Therefore, it is they may require a higher dose of steroid, or it is likely to be less effective in nephrotic syndrome. Another important problem which is very common is obesity, and what is the dose of glucocorticoid which we should use in obese patients. And it is of the most important thing which we should know is the dosing of glucocorticoid should be based on the ideal rather than the actual body weight. So we do tend to see patients who are 80-90 kgs, and we should not give 1 mg per kg as 80 milligram, and rather we should base it on the ideal body weight for their height and give it accordingly. And the bioavailability in obese patients, there are very contradictory evidence whether they have higher bioavailability or lower bioavailability because of obesity. So we better stick to the ideal body weight and the dose of steroid accordingly. So this is another important and commonly asked question, the safety during pregnancy. Both the patients and practitioners should be aware of this. So during pregnancy, the steroid is safe during pregnancy. I think it is pregnancy category B. The lowest possible effective dose has to be used during pregnancy. And as I previously mentioned, the 11 beta hydroxy dehydrogenase, that enzyme type 2 is expressed in placenta. So the prednisolone and prednisone is not likely to cross placenta. But if you would like to specifically target the child, like in our case, we use during congenital heart block, if it is suspected, we would like to give steroid which will cross placenta during 18 to 24 weeks. So we should use fluorinated glucocorticoid, that is betamethasone and dexamethasone has to be prescribed. So that is going to reach the placenta, reach the child. And it is also safe during breastfeeding, and doses less than 20 mg is not likely to reach the child. But if you are prescribing dose which is more than 20 mg, it may be advisable to like discard the breast milk which is secreted up to 4 hours after the ingestion of prednisolone. Subsequent breast milk is likely to have less steroid in it. So these are the two important practice essential. And this also is the most important thing, the impact on vaccination. So it is giving pneumococcal and influenza vaccine during to those patients who are going to require long-term immunosuppression is picking up. Like most practitioners would like to give this, and would like to know what is the effect of the steroid, high dose steroid on it. So according to these advisory committee on immunization practices, if a patient is likely to receive high dose steroid for more than 14 days, the vaccine responses are likely to be suboptimal. So during the acute admission, we are likely to start 1 mg per kg. The vaccines which we give are likely to be less effective and are not likely to mount adequate immune response. So it is a good practice to wait for the patient to be transitioned to lower doses, that is less than 20 mg per kg steroid before we give. And that is for killed and attenuated vaccine. So live vaccines should be avoided during high dose steroid therapy. So these are the recommendations from this committee, Immunization Practices Committee, CDC mainly. Coming to adverse event, this is a very interesting idea which I came across in one of the articles. The fatalistic idea that glucocorticoid toxicity is the price to pay to avoid the consequences of uncontrolled disease and to achieve SLE remission is no longer acceptable. So people are not going to like resign themselves to the side effect just because we would like to control a fatal disease like lupus. So let us see what are the monitoring which are required. In this particular systematic literature review, these are the common sites, corticosteroid related adverse effect according to a lot of published literature. So if you can see, hypertension and diabetes is the most fracture. These are the three most commonly reported, and the other important things are sleep disturbance, cataract, some nausea, vomiting, and other GI intolerance associated with this, cardiac tension which gets exacerbated. So these are the things which we need to, these are the commonly occurring adverse effect, and we need to keep our eyes open to these. So most of the adverse effect of glucocorticoid is related to HPA axis suppression, and it is likely to mimic Cushing syndrome, which is a altered physiological state, disease state. So coming to, I have a detailed table about this. What I would like to just show is it is going to affect most of the organ system: brain, cardiovascular, eye, immune system, adipose tissue, bone, muscle, skin. So we'll discuss these adverse effects in detail from this table. So if you can see in dermatological, this is mainly related to the Cushing's appearance which happens, Cushingoid appearance. Different people are predisposed to developing this Cushingoid appearance, and different doses like dexamethasone is likely to cause more Cushing's appearance if you are giving it for over 1 month and all. And it is going to be less with prednisolone like that. And ophthalmologic is important. If you already have raised intraocular pressure, it is going to get aggravated. So these three are important: posterior subcapsular cataract, glaucoma, and exophthalmos, and cystoid macular edema. So these are the things. So if a patient presents with persistent headache or blurring of vision, so these are the things we need to get evaluated for. So as I have told, high dose steroid can cause fluid retention, and if you are already having some cardiac failure, it is likely to get aggravated. Hypertension is very common, as previously shown. Around 30% may develop hypertension. Premature atherosclerosis is due to multiple reasons. It may be inflammatory state itself due to underlying disease also will predispose to atherosclerosis. The aggravation of hypertension, diabetes, and lipid profile, all that will contribute to atherosclerosis over long term. Arrhythmias, I have already told, some bradycardia and arrhythmias may occur in predisposed individuals during high dose steroid. And Gastrointestinal high dose steroid can cause some amount of gastritis and require PPI, but low dose steroid do not usually require PPI. And if you already have an underlying peptic ulcer disease, it can get aggravated, or if you are giving a high dose steroid for a long time, it may predispose. Steatohepatitis or fatty liver is known. Visceral perforation is a very rare thing. So the steroid myopathy usually happens if you give these dexamethasone kind of preparation rather than prednisolone, or if you're giving high dose for a long time, 2-3 months without tapering. All this can predispose to myopathy. And AVN is a very like a missed, or it may get delayed notification and may worsen. So this is a very important entity which I'll be discussing. Osteoporosis is also a silent epidemic, silent killer in these steroid related side effects, so which we have to discuss. And these neuropsychiatric manifestations are, most of these are during initial high dose steroid. I have come across 1 or 2 episodes of steroid related psychosis, which will subside as soon as you reduce the steroid dose. And this dysphoria or depression is fairly common. Insomnia is also fairly common. Another common thing which we come across is steroid related tremors. So during high dose steroid, some patients are predisposed to this. Once we taper the steroid to less than 0.5 mg per kg, it comes down. Pseudotumor cerebri is another condition which we need. I don't commonly come across. Metabolic and endocrine, the hyperglycemia and frank diabetes can happen due to steroid in predisposed individuals. And increased risk of infection I will be discussing a little bit in detail. This leukocytosis is due to demargination of neutrophils, which happens due to high dose steroid, and we commonly see that during high dose steroid therapy, patients will have total WBC count which is higher than normal, and it may or not indicate infection all the time. So let us go to some of the manifestations which we require detailed discussion. So I have previously told about the mantra of prescribing steroid for the lowest possible or the of dose which is more likely to be most optimal and for the shortest duration. This particular study is showing the same. So the glucocorticoid dependent side effects are likely to occur earlier if you are using higher dose of steroid as a maintenance rather than a lower dose of steroid. So if you see if you are not using prednisolone, you are not likely to develop, if compared to this. Even if you are using less than 5 mg per kg prednisolone, over long term you are going to develop some or the other serious adverse effect. This was in some rheumatoid arthritis patients, little bit older age group. So there is a clear dose dependence of side effects. So that is the thing which I would like to tell. On a long term low dose maintenance steroid, please try to reduce the steroid and maintain it at the lowest possible dose, and give the high dose steroid for the shortest possible duration. So the risk of sepsis is one which is very most important thing which we should know about glucocorticoid. The risk of infection is likely to be different depending on the age, the most important thing. Elderly people are most predisposed. Underlying illness like lupus. Lupus patients are having 6 to 7-fold increased risk of serious infection than general population while on steroid. And comorbidities like uncontrolled diabetes, etc. So this particular study, which was published in 2016, in patients who are having like minor organ lupus, mild lupus, and requiring steroid, they have compared with those who were not started on steroid and just on anti-malarials, and they have found that this was a community-based studies involving 2,300 patients. They found that the risk of infection is around 3.9 times more than those who did not start steroids. So this is all like they are matched lupus patients who have mild disease, and we assume that the disease per se is not predisposing them for infection. So the whatever increased risk, that is around 4 times, is likely to be related to low dose steroid. So the risk of infection is there in both high dose and low dose steroid. So this is another study which was done in giant cell arthritis. So all these patients are older, 60 plus individuals. So what I would like to tell you, these are all the maintenance doses of steroid. So what they are trying to tell is the risk of infection over long term. They have followed up these patients over 15 years, I think. And the risk of hospital admission and the risk of dying due to infection is dose related. And like for example, if you are using like more than 25 mg of steroid in the recent past, the risk of infection, all cause infection is 2.3 as compared to if you have used less than 5, that is 1.39. So that is one thing. And cumulative dose over the last year, that is also going to predispose you to infection. So if your cumulative dose is like less than 1000, your risk of infection is likely to be less, like here cumulative dose over in the last year. So if it is less than 1000, it is 1.88. If it is 1 gram to 3 gram, it is around 2.5. If it is more than 3 gram, it is 3.23. So it is related to the long term maintenance dose of steroid. It is gradient is there with respect to whatever is your maintenance dose. Also it is related to the cumulative dose of steroid over the last year. So this I found is this study is giving a very important message with respect to steroid use and risk of infection. So of this 40,000 people, these were all general practice, these giant cell arthritis patients who were being followed up under general practitioners. So they have looked into 40,000 of these people, and they found that around 55%, so that is more than half of these individuals have at least one infection over a median follow-up of around 4.8 years, and around one third of these who have had infection have required hospital admission for infection, and it is mostly related to this steroid. And around 7.3% have died within 7 days of diagnosis of infection. So this is the seriousness of the morbidity and mortality associated with infection predisposed by glucocorticoid usage. This is particularly important in elderly population where we usually diagnose GCA. This is another study which has looked into risk of infection in glucocorticoid exposed individuals of our rheumatology practice. 7 diseases of interest, including GCA and lupus rheumatoid arthritis, were compared. What they found was, if you can see the glucocorticoid use versus those who have never used glucocorticoid, when you have adjusted for their age, their gender, and underlying comorbidities and other immunosuppressant, even after adjusting, just the glucocorticoid use is associated with cellulitis, septicemia, and candidiasis and zoster. So this is unequivocally associated with risk. The risk ratios are given here. Candidiasis 5.7, zoster 2, cellulitis 2, and LRTI is around 5. So these are this you can see. So these are the infections which are commonly occurring, are unequivocally associated versus those who have never used steroid. Okay, this is about the other infection, and I would just one slide about the use of glucocorticoid and TB reactivation. So this is one study which is from Taiwan. So they have looked into 6,021 cases of pulmonary TB versus 6,021 control, and they have assessed what is the risk of steroid use and development of tuberculosis. The adjusted odds ratio for development of pulmonary tuberculosis in steroid users versus never steroid user is around 1.91. And if you have used oral corticosteroid for more than 3 months, the risk is around this much. And dose is associated. So the dose dependency and the risk of TB reactivation is also there. So coming to glucocorticoid and osteoporosis, this is something which we should all be aware of, and we should always screen for those who are predisposed and those who are on high dose long-term steroid. So according to, from point of view of osteoporosis, conceptually they have categorized into 2 categories. Glucocorticoid use, the long-term glucocorticoid use is less than 7.5 milligram per day or high, that is more than 7.5, and assessment of fracture risk. And anyone who has previously received glucocorticoid for more than 30 mg per day and has received a cumulative dose of steroid of more than 5 grams. So if you see one admission, acute admission, and patient has received a pulse glucocorticoid of 1 gram for 5 days, will cross this threshold. So anyone who has received pulse steroid, according to the current practice, is going to be come under this category who requires evaluation for development of GOP. GOP is the short form. for glucocorticoid-induced osteoporosis. So they will have increased relative risk of vertebral and hip fracture. This is from all these population-based studies. And an interesting thing, and we should always be aware of, is this is a potentially reversible risk factor. So if once you cut down the glucocorticoid treatment, once you reduce it or you terminate it, this risk of osteoporosis and its related fracture is going to reverse over time, unless the patient has other risk factors for osteoporosis. So this is the latest guideline which was published in 2017 for prevention and treatment of GOP, glucocorticoid induced osteoporosis. They have categorized patients into those who are less than 40 and children also I will be discussing briefly, and those who are more than 40. As you may well be aware of, we don't get T-score for those who are less than 40. So what we get is Z-score. So if we'll first cover this. So in like our lupus patients and all who are tend to be younger, they are less likely to be less than 40. So if they have a prior osteoporotic fracture, they come under high fracture risk category. Or if their Z score is less than minus 0.3, or if they are having a rapid bone loss over a year, or they are requiring to continue high dose, like more than mild dose, that is moderate dose of glucocorticoid for more than 6 months. So anyone who may likely to take more than 7.5 mg of glucocorticoid for more than 6 months is also coming under moderate risk. If none of these are present, then this age group people are not likely to have increased risk of GOP. Coming to adults who are more than 40 years, from the FRAC score, which is a risk assessment score, it can be used for any fracture. Osteoporotic fracture risk assessment score is called FRAC score. We have a glucocorticoid adjusted FRAC score. This software is available online. You can check it out. So it is going to assess 10-year risk of major osteoporotic fracture. We can do this only for adults who are more than 40 years of age. So from FRAC's calculation, if you are getting the fracture risk of more than 20% and risk of hip fracture of more than 3% risk category, and anyone who has a T-score of minus 2.5 in men, and in women more than in men more than 50 years and postmenopausal women is automatically coming under high fracture risk. So if any one of these, any adult who is more than 40 has a prior osteoporotic fracture or has a T-score of minus 2.5, then they automatically come under high fracture risk. In others, you have to calculate, like if they have a better one, minus 1.5 to minus 2.5, then you may have to calculate based on FRACs. So moderate fracture risk comes under intermediate category, 10 to 19% and less than 3%. And low fracture risk is if they have less than 10% according to FRAC score and less than 1% according to for hip. These slides are not seen again, sir.
I'll just load once again. Yeah, sorry for this.
Yeah. Hope I have not overshot the time. It's almost time. Sir, can you go to that slide?
Hello?
Can you go to that slide directly, sir? It may have to.
Okay.
We can go like this.
No, it's okay. I will do it.
If we escape, we can go directly.
It's okay. We are almost there. This one?
It's not seen, but
okay. Slight lag, I think you will get it. There is a lag. Are you able to see or?
No, sir. Shall I move myself?
You can take control.
Okay. So the other risk factors which needs to be assessed are malnutrition, significant weight loss or low BMI, hypogonadism, secondary hyperparathyroidism or thyroid disease, family history of hip fracture and history of like severe alcohol use. These are the other risk factors which we should always assess in both these age categories. This is just a flow chart which will tell us what are the minimum possible treatment which is required. So for the low risk people, you need to just reassess every 2 to 3 years. And if they are continuing to take moderate to high dose of steroid, you may have to like see in detail if they are likely to develop fracture. Moderate to high risk individuals, you need to give them vitamin D and calcium in everyone. Women of childbearing potential, it is better to avoid oral bisphosphonate. You can consider teriparatide if they are having moderate to high risk. You can treat with oral bisphosphonate in rest of the people. The other therapies like bisphosphonate, teriparatide and denosphenoxazole is coming like in the second line therapy in the order. If there is any uh, contraindication, you can use. So for postmenopausal women, raloxifene is also another option. So this is other than GOP, this table is discussing about what are the monitorings which may be required in adults who are on long-term corticosteroid. For children, you need to monitor growth every 6 months and you plot it on a growth curve. If the growth velocity is inadequate, you have to refer to a pediatric endocrinologist for further assessment. This is the most important thing if you are giving steroid to children, the assessment of growth. The other risk factors are less likely to affect them that much. So dyslipidemia, you can assess lipids during the initial initiation and every 6 to 12 months depending on the risk factors, other risk factors and the dose of steroid being used. You can assess cardiovascular risk using this Framingham risk score every 10 years. So you should screen for diabetes initially and if they develop frank diabetes based on the symptoms. And during the initial IV steroid initiation, anyway, we will monitor the glucose during that time. Then every 3 to 6 months for first year. What we usually do is during the first follow-up visit, I usually check the random blood glucose. And subsequently, 3 to 6 months. And for children, maybe less frequent monitoring is enough. Ophthalmic examination, if they have symptoms, you can directly refer. And if your early referral may be required if they have additionally diabetes and previously they have myopia and history of glaucoma is there. And the other, we will discuss few of the adverse effects in detail. Osteonecrosis is of particular interest to every one of us because it can develop in 9 to 40% of adults and it usually happens in those who have received previously high dose steroid and subsequently long-term oral glucocorticoid. So this is the subset which we commonly see, and if they have additional risk factor like lupus, APLA, alcoholic, all those are going to predispose. So the other risk factors for osteonecrosis is going to be additive in those who are already receiving steroid. But it has also been found to occur in those who are receiving short-term and low doses of steroid also. And in a study of 270 cases of glucocorticoid-induced AVN, 79% experienced pain within 3 years of glucocorticoid. So the median duration at which AVN has developed in those who are receiving long-term glucocorticoid was around 18 months. So when to suspect osteonecrosis? A lot of time it may go unnoticed. The importance of picking it up early is a grade. There are some grades of this osteonecrosis about which I will not be going into detail. FICAT staging. So the FICAT stage 1 and 2, it is amenable to some minor intervention by the orthopedician and you can avoid complete destruction of the joint. So it may not get progressed and hip arthritis, secondary osteoarthritis may not develop. So if any patient who is on high dose steroid or long-term steroid and you are suspecting osteonecrosis and X-ray is normal, please go ahead and do MR imaging because X-rays is less sensitive. This is advanced osteonecrosis. You can see areas of necrosis. This is MR imaging. So MR imaging picks up quite early. So coming to HP axis suppression, this is also an important thing. It is of relevance when people call us over for consults, cross consultation, or when the patient develops some stress situations. We should all have a working knowledge of what are the features of adrenal suppression. So people who have discontinued steroid for up to a year or more, they may continue to have this adrenal axis suppression. So anyone who has received a dose of steroid of more than 15 mg for more than 3 weeks is likely to have HP axis suppression. So which applies to all our patients. So once we taper and stop steroid, they may come back with these features of adrenal suppression or crisis. So anyone who comes with hypotension and unexplained hypoglycemia, hyponatremia, seizure, coma, all these may be related to adrenal crisis. These are the features of suppression. So they may have fatigue, arthralgia, nausea, vomiting, diarrhea, abdominal pain, myalgia, some psychiatric symptoms. All these may be features of adrenal suppression. This poor linear growth in children and all will require pediatric endocrinology consultation. So duration of glucocorticoid therapy and dose of glucocorticoid treatment are not reliable predictor of which patient will develop adrenal suppression. So this is the most important thing which we need to keep in mind. So we can think that we have given very low dose or less steroid for a short duration. This is unlikely to happen, but it happens at various dosages. So we need to keep it in mind. And also inhaled and topical use also is known to cause adrenal axis suppression. So screening recommendation, when to screen. So if any patient who has received corticosteroid for more than 2 consecutive weeks or more than 3 cumulative weeks in the last 6 months is likely to develop adrenal suppression. Patient has persistent symptoms, also you need to screen. These symptoms I have already referred to. How to screen? Measure early morning cortisol. So that is one way of finding out. And you can do cosintropin test. So if the early morning cortisol is less than 85 nanomole per liter, please refer to the appropriate SI units and whatever is reported in our laboratory. So if anyone who has less than 85 nanomole, I think it's 0.5 or something according to our lab. So it will be diagnosis of AS will be confirmed. So if you have suspected and if early morning cortisol is this much, it is confirmed. And if it is just below the laboratory normal, then you may have to take endocrinology consultation for cosintropin test. So tapering regimen. So this is also an important thing, practice essential. So usually you can reduce steroid by 5, like after once you reach something like 10 mg or 15 mg, then you have to slowly taper. Before that you can taper quite fast and it is not going to lead to HP axis suppression. So once you reach something like 15 mg, you can taper 2.5 to 5 mg decrements every 7 days until physiologic dose, that is 5 to 7.5 is achieved. Slower tapering is required. More slowly you can taper if you think the disease is going to relapse. And the other thing is, if a patient is particularly predisposed to HP axis suppression, you can switch to hydrocortisone and then you can taper slowly and stop. Okay. And then you can reassess the HP axis and see whether it has recovered and all that. This, I think we are shooting we are way out of time. I think I'll just go ahead. So the other thing is, what is the stress dosing which has to be required? As I previously mentioned, if the patient is on some 15, 20 mg, 10 mg prednisolone, they will require around 100 mg per day of hydrocortisone, which is divided into 3 equal divided doses, depending on the severity of the illness and surgery. So if the patient has a severe medical illness, it may be better to give them around 150 mg per day of hydrocortisone, that is 50 mg 8 hourly. And if they have critical illness, you can give little bit higher doses. But if they have minor procedure or minor illness, 25 mg per day or up to 75 mg per day will be sufficient. So this I'll just briefly go through because I just want to highlight the change in paradigm in the way we use steroid of late. So these are all latest update. So we have, for a long time we didn't have any update on how to use steroid. So we have one EULAR recommendation of use of steroid in large vessel vasculitis, which includes GC and Takayasu. If you can see, earlier polymyalgia rheumatica we used to use 40 mg as induction. Now it has come down to 25. Even for giant cell arthritis, a little bit higher dose pulsing and all were recommended. You can see now it is just 40 to 60 mg. And pulsing as per your clinical indication you can use. You can see that the tapering is also slightly faster. So taper it by 10 mg by around 4 to 8 weeks and then you reduce it further. And here also you can see taper it fast. By 3 months they would like us to taper. And and by around 1 year, please maintain around less than 5. Okay, so this is a important change. So compared to previous, this is another study in multiple sclerosis which I came across here. They have compared oral methylprednisolone group versus IV methylprednisolone, and they found that it is non-inferior. So there are some changes in the way steroids are being used in clinical practice. This is another very interesting study, PEXIVA study, which is recently published in vasculitis. So this is for ANCA vasculitis. So they have compared two things. One is whether Plex is useful for these organ threatening, that is DAH and rapidly progressive renal failure. The other thing which they tested was whether lower doses of steroid in these very sick patients, this subset included very sick patients, and they have compared higher doses of steroid versus lower dose. If you see the lower dose steroid by week 2, they have cut down to 30. They have mostly used the pulse steroid prior to this, and once pulsing is done and cyclophosphamide etc. is used, so they have cut down to 30, and if you can see by around 6 weeks it's around 20, and by around 12 weeks, that is 3 months, already they have come to 10. So as compared to the standard protocol of using 20 and 50 up to 4 weeks. So we use almost 1 mg per kg for around 4 to 6 weeks. So compared to that practice, the lower dose is found to be non-inferior. So treatment with lower glucocorticoid regimen was found to be non-inferior to treatment with higher dose. And of note, most of these people have received endoxone and very few have received rituximab. And the other important thing is those who have used lower doses have developed fewer serious infection within first year of treatment. So this is the advantage of getting tapering steroid faster once you initiate second line agent. So this is our lupus recommendation. This is not really evidence based, but what they recommend is to minimize the daily dose as fast as possible and to use pulsing and start lower starting doses. That is, once you pulse, please start at 0.5 mg per kg if you think that the organ manifestation is not very severe or not likely to progress. Instead of starting at 1 mg and slowly tapering over 4 to 6 weeks, you can start at a lower dose. That is what they are recommending. So this is the ITP recommendations who are also adopting this lesser dose of steroid to be used, and they are using this DEXA pulse, which I have previously alluded to, instead of methylprednisolone, high dose methylpred pulse. So this is a summary slide of neurological indications which I have alluded to, and dosing, which is very important, and what are the evaluations which we have to do. The major most important contraindication is frank sepsis. Otherwise there is no other great contraindication. They have to modify the dose according to comorbidities. The monitoring and all recently I have discussed, so I will not be going into this thing. So any questions, I would like to take it. Otherwise thank you for this opportunity to talk to you people.
Dr. Ramya, thank you very much. It was an excellent presentation, very, very detailed, and you have covered almost everything. I'm sure there will be a lot of questions. So I request the participants to raise their hands and we can start discussion. Just to avoid crosstalk, they can raise the hand first and then ask questions. Meanwhile, before people ask the question, can I ask you a few things, Dr. Ramya?
Yes, sir. Yes, sir.
See, I read about pulse methylprednisolone induced liver failure, fulminant and fatal liver failure.
Yes,
We don't
sir.
monitor liver function tests during methylprednisolone therapy. Do you think it is required? Do you monitor? What is your practice?
Not really, sir. I mean, unless they have some underlying chronic hepatitis and all, Hep B, Hep C, which will get flared up because of steroid. Steroid per se can cause over long-term fatty liver. There is no acute complication which I have never come across, and I didn't see in any of this literature also.
Okay. Apparently, in Graves' disease, there is a study in European centers.
Yeah,
They
yes.
found that 1% had this. Whether it is peculiar to Graves, we don't know.
Okay.
What about thrombotic events? Do you see thrombotic events like coronary events?
No, sir. Unless the disease, like some vasculitis patients and all, which disease per se may have predisposed, we have never attributed thrombotic events to steroid per se.
Okay, there are reports of stroke and MI. Some of them, half of them are fatal, but very rare. So we never saw that,
Some
or we missed it.
arrhythmias and all, it is predisposing. Likely, I don't. It is possible.
Okay. Then there is also a lot of mention about threadworm and amoebiasis. Apparently, we are supposed to treat it before giving steroids. Otherwise,
Oh.
they can cause fulminant infection and even fatal. Do you routinely treat them before giving
Stronger lights,
steroids
no,
long
sir.
term? No?
We had during CMC, we used to consider that maybe there is some strongyloid infection which is predisposing to gram-negative sepsis when we give them
Okay.
high-dose steroid. That was one thing which we considered, but there is no conclusive evidence from literature that it is predisposing. So we are not doing it, sir.
Okay. Another question is, suppose patient develops leukocytosis on steroid therapy.
Yes.
How do we know it is due to steroid effect or it's an infection which is building up? How do you differentiate the two?
One
Clinically, they
thing
may
is
be silent
clinically, if
without
there are
symptoms.
no other features, one marker which we all commonly use is CRP, sir. Unless
Right.
diseases like lupus, CRP tends to be very low when during active disease. So if CRP is high, and if it is high, it is most likely to be due to infection and not due to steroids.
Okay. Okay. Then the other thing is you have shown a chart comparing various types of steroids,
Yes, sir.
DEXA, beta, methyl, prednisolone, etc.
Yes.
In that, the DEXA and beta 5 times more have a more anti-inflammatory effect than methyl
Yes.
prednisolone,
Yes. Yes. Yes.
and methyl prednisolone has 5 times more than prednisolone. Is it
No, sir. The non-genomic effects are more with methylprednisolone. Genomic effects of prednisolone and methylprednisolone are comparable. So over long-term
equivalent?
usage, they are both same. So during this acute pulsing, methylprednisolone is better than others.
For your routine oral therapy, do you use methyl prednisolone or you still using
We are
prednisolone? What is
using
your practice?
prednisolone, sir. CMC they
Why
use
not?
Defcort. They are using. They,
Okay,
although there is no
because
conclusive evidence that the side effects are lesser with Defcort, we are using prednisolone only, sir.
the mineralocorticoid effects are less with methyl. Why not we
They
switch
are
over
all
to that as a
compares.
routine?
I mean,
But
according to this, the prednisolone and methylprednisolone have comparable mineralocorticoid activities. The
but
difference
synthetic
is only
steroids
with height.
less, no?
Yeah, but
Synthetic.
no, sir. Prednisolone is also synthetic only. So they
So
are whatever from according to the table from up to date, it is almost same, sir. So we are
oh,
our common practice. It is just out of practice that we use prednisolone.
okay, right. So I think one issue peculiar to neurology I will mention:
Yes, sir.
myasthenic crisis. We are
Yeah,
not
yeah.
supposed to give steroids.
Yes.
Okay, we are supposed to give IVIG or other
Mm,
plasma exchange and things like that,
mm,
because it
mm,
can cause acute myopathy, which takes 1 year, even 1 year to recover.
mm, mm,
So
mm.
I think the common thing is in ICUs, intensivist start methylprednisolone,
Mm,
like any
mm,
other
mm.
immune disease. But in myasthenic crisis, we must not give that. We
Yeah.
should directly go to
Right.
IVIG.
This is an important, I think we should spread this message in the intensive care settings.
Yes. Another thing is Bell's palsy in pregnancy. We see quite often.
Yeah, yes.
And we are a bit hesitant to give steroids. From your presentation, it appears that
So
prednisolone
steroids
is
are very
quite
safe,
safe.
sir. We use a lot of steroid during pregnancy, and
Okay.
at least the shorter pulses and shorter courses are not likely to have any effect on the baby if we are using prednisolone and prednisone, etc. They are not likely to cross. Yes.
Methylprednisolone?
That also is
Methylpred?
not likely to cross, sir. Only DEXA
Fine.
and betamethasone will cross.
Great. That's all from my side. We'll wait for any questions from the audience before we close it. Maybe 5 minutes we'll wait.
Yes.
Any questions, please? You can unmute yourself and ask the questions. Very silent audience. This oral methylprednisolone you mentioned, equivalent to IV, I think
Yes.
the dose is equivalent, 500 mg methylprednisolone, isn't it?
What I didn't understand. I didn't get your question, sir.
You mentioned that IV methylprednisolone and oral
Ha
methylprednisolone
ha
are
ha.
almost
Yes. Yes.
equivalent,
Yes.
but the
But
dose also
this
is identical,
multiple
500
sclerosis
mg.
study.
Yeah,
Multiple
it
sclerosis
is
studies, sir.
correct in that the dose is 500 mg oral.
Yeah.
We
Yes.
don't get that high dose preparation in India. We get 8 I think 4, 8.
No, I was searching for any studies on the steroid dosing and I found this. I just wanted to project because just to tell
But
that it has good
is
bioavailability
that
in both aspects.
is that available? That strength of medication like high dose
No,
oral
sir. This
methyl?
is a very good publication in Lancet. We are not using, sir, this high dose
It's not
methylprednisolone
available.
oral.
That
Yeah, it's not
yeah,
available.
it's not available. Yeah.
Sometimes
Okay.
I have used oral DEXA for some people, pulse DEXA for
Okay.
management of hematological manifestations on OPD basis, oral pulse
Okay.
DEXA.
Right. And this avascular necrosis we have seen
Yes.
even with short-term
Yeah, yes.
steroids.
That they have mentioned, sir. Even with whatever dose of steroid it is happens. It is
So
probably
we
the
cannot
other
predict.
risk factors maybe there. There are no predictors, sir.
I think smoking is one thing that is
Yeah,
mentioned.
yeah. The additional
Unfortunately.
risk factors have to be kept in mind. Smoking, alcohol use, and
Right.
APLA, lupus. All these are
Yeah.
considered as risk factors.
Sir, I have a doubt.
There is one question.
Mm,
Yeah, role of PPI prophylaxis in
Yeah,
chronic
high
steroid
dose steroid,
use.
high dose steroid will require, but I think moderate to low dose steroids are not really associated with so much of gastritis.
So we don't have to routinely give the PPI.
Low dose steroid definitely not required. NSAIDs on
Okay.
a regular basis require PPIs, but low dose steroids are not associated with so much of gastritis. I never give.
Calcium
Less than
plus vitamin
20,
D
I
you
don't
have to
give.
give.
Calcium and vitamin D is a must. That is one thing which I would like to stress again. Anyone you are starting on steroid therapy, please empirically, you don't really have to check even vitamin D. Vitamin D and calcium has to be replaced. You can complete the course of vitamin D and continue calcium till the patient is on steroid.
Right. And the dose of calcium that you use in steroids,
We are using 500, but what is recommended is 1 gram at least, sir. At least in
1 gram
postmenopausal
per day.
women, 1 gram. Postmenopausal women,
Okay.
1 gram.
Okay. There are few more questions coming. Can we wait? Can you wait for a minute?
Yes, yes.
Rohit, can you unmute and ask? There is no need to. Rohit. Okay. What he has asked: patients with calcified granuloma and edema, and they have seizures. What is the role? This I had to answer. If the edema is mild, there is no need to give anything else. No need of steroids also. But if there is a massive edema, which is not very common, then a short steroids may be required. It is a vasogenic edema, so steroids will help, but it is required only if there is a massive edema. We don't normally see massive edema around calcified granulomas. Another good question is Bell's palsy with diabetes.
I
Are
think,
steroids
sir,
worth
you
it?
are likely to explain it better
Okay.
than me.
Yeah, Bell's palsy in diabetes has a ischemic basis. So normally we don't have to give it. But if patient has a severe Bell's palsy, then what we do is we admit the patient. We often need to give insulin. Under the cover, we give a short course of steroids. That's what we do. But like all other cranial neuropathies, the mechanism is more of ischemic,
Microvascular.
microvascular. Few more are coming. Please wait.
are you free now?
You can
Hello.
unmute and ask. Hello. Dr. Seshagiri, Dr. Meenal, you can unmute and ask the questions. To save the time, please unmute. I'm not sure whether they're typing or.
Bala Prashant Babu.
Hello?
Bala Prashant Babu is typing.
Yeah,
I
you
think you
can
can
ask
unmute
Dr.
and ask
Prashant.
directly, I think.
Yeah, this saves time. Just ask the question. Prashant. Dr. Prashant, unmute.
The role of procalcitonin in differentiating the leukocyte is associated with the glucocorticoids and then infection. What is the role?
CRP is actually, I mean, enough actually. But
Procalcitonin.
if you're specifically concerned about gram-negative sepsis, then you can go ahead and do.
Okay.
Otherwise, I think in most of our conditions, we commonly use CRP because clinically we will be able to differentiate that we will have a feeling that this is just steroid related. Just to differentiate that CRP is more than enough. Otherwise, if there are other clinical pointers to sepsis, then anyway you will do all these cultures and very high this toxic granules and all neutrophilic leukocytosis, which is associated with toxic granules. All those other markers will be there, which will tell you.
Madam, bisphosphonates in young patients when on long-term steroids.
Those who are having moderate to high risk, we are using, but in children we don't usually use unless they have had an osteoporotic fracture. Less than 18, it is not considered safe, but more than 18 and if they have moderate to high risk, you can go through that table. It is explaining quite well, the table and the flow chart. If they have moderate to high risk, they are likely to continue high dose of steroid for quite more than 6 months. Then you can start bisphosphonate and you should avoid pregnancy.
Not take leave, press CTRL, shift and B together and see.
I don't know. I can see that somebody is typing, still typing the question. We should wait. Dr. Meenal. This entire presentation will be uploaded, Dr. Ramya,
Yes,
in
sir.
the website.
No problem.
Neurodrugs.com is the website name.
Yeah.
So the video will be there and separate PPT also will be there.
Okay.
So I think that should be enough. Yeah, I think we can close. Thank you very much once again. It is wonderful talk. Very, very informative talk. Thank you for the talk.
Thanks, sir, for the opportunity. Thank you.
Yes. Thank you.